So the fate of aspirin, it will soon disappear. I like that. Thank you, Dr. Sharma, for putting me up for that. Lots of disclosures as usual. So Dr. Bhatt failed to tell us a little bit about some of the problems and issues with aspirin, and it seemed like the bleeding risk, yes, of course, he talked about it and really said reserved taking aspirin away maybe for those patients who are at risk for bleeding. But I think there are important quote unquote aspirin resistance. We talked about the enteric-coated, the drug-drug interactions, the medication non-compliance, the premature discontinuation, all of those things. And then, of course, the fact that there is this very, very important gastrotoxicity that occurs with aspirin. And very important U-shaped curve here on the response curve to aspirin that's been very well documented, showing lower is better. And I wonder, in combination, when you have other potent agents on board, do you actually need it? And there was this very, very important fact or fiction situation where there was the aspirin dose and ticagrelor benefit in Plato that was played out very, very nicely, showing that maybe at 0 dose you might even be best. And I think it was a very, very important segue to this understanding of the interaction between P2Y12 inhibitors and aspirin, such that the P2Y12 inhibitors stimulate inhibiting the inhibition of adenyl cyclase, thereby increasing cyclic AMP. So in some ways, kind of refuting their benefit at the same time. And it might abolish or decrease the proposed antithrombotic effect of P2Y12 inhibitors. And this is something that has been interestingly debated over time. And in fact, there's been very important basic experiments that have been done with looking at platelet aggregation and showing with prasugrel, with the potent agent prasugrel, for example, plus aspirin versus no aspirin, looking at the platelet aggregation, showing that in presence of a potent P2Y12 inhibitor, such as prasugrel, aspirin provides little inhibition of platelet aggregation. And this has been also documented with ticagrelor to some extent, and importantly showing this very important comparable inhibition of hemostatic system between P2Y12 inhibitor monotherapy and DAPT. So why drop aspirin? I say why not, because obviously we just talked about the fact that at higher doses you could have an important issue. It's really a weak antiplatelet agent. The low-dose aspirin was better than high dose. We'll talk about that a little bit later in Plato. And then we'll talk a little bit about dropping aspirin in when there is that triple therapy situation. It's all about that balance. We talked about it. Dr. Bhatt discussed it. And I think it is very important to kind of put that against each other. Yes, of course, myocardial infarction, intracranial ischemic stroke is incredibly important, but so is bleeding, significant bleeding, and not just intracranial bleeding, because if you look in the TRACER study, for example, and look at MI versus bleeding and its impact on mortality, which is what matters, you can see that as you move forward into higher bleeding situations, you're going to get even a much, much more important net benefit in favor of having less bleeding by bleeding avoidance strategies such as dropping aspirin. And what is the evidence on aspirin in, especially in PCI patients? And there's very limited data, actually, for understanding what the true benefit is on top of the P2Y12 inhibitor. And this balance of bleeding and ischemic complications have to be put into the equation. I'm going to just not talk about the primary prevention. Aspirin is getting some really bad rap in primary prevention. And I'm not here to say that we should take it away in secondary prevention. I think that's a big fallacy. We need these types of studies before we say anything whatsoever. But for primary prevention, we saw that bleeding was significantly higher, and there was no real effect on mortality. There was some, as Dr. Bhatt discussed, a reduction in ischemic complications in the ASCEND with the diabetic patients. But in here, if you really look at bleeding and mortality, you really are not showing that important benefit. And yes, you can argue that what is important, what's more important, it's all about what the patient cares about. Of course, nobody wants an ischemic stroke, but neither does that same patient want an intracranial hemorrhage. I think we really, really have a very, very fine line to cross here when we are moving in that direction. We are now at the 10-year anniversary of the Plato study, I think one of the most impactful trials showing this very, very important benefit of a potent agent that reliably reduces and inhibits platelets. But the change in guidelines occurred. The registry data showed that we're now increasing the use of ticagrelor, but there are still very, very important questions left, especially on the aspirin interaction and the fact that the US patients didn't do very well with ticagrelor. And so the success of the low-dose aspirin in Plato made it a very, very important black box warning, in fact, an important complete indication for the low-dose aspirin in combination with ticagrelor. So if less is more, then is none even better? And that's really the big, big question that we need to know. Now, we talked about global leaders, but I would say that global leaders was a real missed opportunity. It really, I agree that they tried to accomplish too much with a single trial, with too many. The experimental arm was very simple, but the control arm was just all over the place with so many different reference therapies to compare to, and the adherence to a 2-year endpoint with no adjudication of some of these important granular events really, really gave us a missed opportunity. And I think that while global leaders just missed the p-value, it makes us come back and think about this as an important opportunity, because at 1 year, they did have a positive result. And the question of where we are later is very, very important, because bleeding does matter. And as you can see here, and we're moving towards a shorter duration of dual antiplatelet therapies and thinking about the high bleeding risk initiatives. And these stacking of these therapies is an unappreciated enemy. And to me, honestly, can we safely withdraw? And I'm going to just go because I see Dr. Dengus here standing next to me, wants me to get off. Is the perfect storm of now thinking about what is happening. The new potent P2Y12 inhibitors in stenting, the unanswered questions after Plato, the missed opportunity with the global leaders, the increasing focus on bleeding, finally figuring out that that really does matter. It's not just a couple of units of blood transfusions. The concern about stacking therapies and exposing patients to more and more bleeding as if it doesn't matter. And this very important fear of aspirin-related bleeding and lack of benefit in primary prevention gives us that perfect storm to test the real true need for aspirin. And I think that perfect storm is why Twilight becomes extremely important and why we await the results of this, TCT 2019. Thank you so much.